Good evening, everybody, and welcome to this online anesthesiology masterclasses. It's a pleasure and privilege to be with all of you again. We went through several aspects in anesthesia. We started off, I think, with diabetes, then we went to pulmonary aspects. We had extensive discussions on cardiac aspects and anesthesia. And today we will take over about something possibly not that glamorous, but very, very important for an anesthesiologist, a person with liver disease, hepatic dysfunction, who could come in for various kinds of surgeries of the non-hepatic kind, as well as that same person could come in for an hepatic resection, or a person without liver dysfunction could come in for an hepatectomy as a donor for a transplant. We also have something which is a very favorite question from the examiners, as well as in the theory, which is tips. So we'll give you some tips about tips, anesthetic management. And finally, we'll wind up with anesthesia for liver transplantation. I have the pleasure of having Dr. Shweta Dotto and Dr. Shimontika Ghosh, both students who did their DNB at Apollo Gleneagles Hospitals and are now consultants in their own right, very well established, doing extremely well, which gives us great pleasure and real happiness. Then they are at Narayan Hridayalaya hospitals at Mukundapur and Howrah respectively. So they will take it up after I finished the basics. So I will start off with my presentation on anesthesia for patient with a liver disease. I'll just wait for the slides to load up. One of the beauty of this web-based platform is that I can already see there are more than 50 people, even before the first slide has come up on the screen. And 50 people, again, I keep saying this in a hall, is something that we look forward to whenever we are doing a face-to-face conference or a CME. Yeah, so what I will try and go through, I'll try, it is very comprehensive, so it might be a little longer than you think, but I'll try to rush through it as much as I can. And the beauty of this, again, is that you can go back to the Edu HCP forum and have a relook at the presentation, relook at the slides, and kind of then delve upon it at your leisure when you have time as well. So anesthesia for a patient with liver disease who comes in for a non-hepatic surgery. I think this is a no-gamer. It's intuitive. Patients with liver disease, then who do not have liver disease, who come in for a surgery, their surgical anesthesia-related complications are much more than those with a healthy liver. And the magnitude of this risk depends upon the type of the liver disease and its severity, the kind of surgical procedure that is happening, and to small extent on also the type of anesthesia or the anesthetic management of that patient. What we will go through is the screening of a patient for a liver disease, the liver disease and its associated risk. Not all of them are the same. There are some with unacceptable risk on which surgery cannot be done. The two most kind of read up or discussed is ones with a variable risks. Those are with cirrhosis and obstructive jaundice, much more elaborately dealt with. And there are certain minimal disease patterns who do not possibly have that great amount of risk than those with the previous. What are the lab evaluations we can look at? How do we look at the associated organ functions and their evaluation? A little bit on how the liver affects the anesthesia and how the anesthetics affect the liver, and what are our perioperative goals, and especially with emphasis towards coagulation and hemodynamic management. And finally, we'll wind up with the postoperative surveillance. Like has been the norm, I think we will go through the first of the audience questions. So this is again just a simple exercise. Postgraduates love it because it's kind of at the outset they can understand how much they already know about this topic, and feel free to answer. There is nothing like nothing is revealed as to who is answering what, but it's good to have a kind of estimate about what you are thinking and what you are doing. So the first poll question, you can check any click on any one of these which is correct. In a patient with advanced cirrhosis of the liver, which of the following lab parameters are you most likely to encounter? Okay, is it an increased AST/ALT, increased conjugated bilirubin, decreased albumin, increased P time, prothrombin time, and a normal alkaline phosphatase? Or will you see an increased ASTL, the transaminases, increased unconjugated bilirubin, increased albumin, increased P time, increased alk phos? The third option is decreased transaminases, increased bilirubin, decreased albumin, decreased P time, decreased alk phos. Or the last option is increased transaminases, increased conjugated bilirubin, decreased albumin, normal P time, and an increased alk phos. So which combination are you most likely to encounter? Okay. So Uditi or Arnab, just don't close the poll till I tell you to close the poll. All right. So we will go to I think we have already closed the poll. I'll go to the next one. Okay. In the child-pox Tourette score or the child score or the child-pox score, whatever, which combination is correct? We can have the next poll. Which is the correct combination? Is it a combination of encephalopathy, ascites, bilirubin, AST, ALT, prothrombin time, and INR? Or is it a combination of encephalopathy, ascites, bilirubin, albumin, P time, or INR? Combination of encephalopathy, cirrhosis, bilirubin, albumin, platelet count. Combination of heart failure, ascites, bilirubin, AST, ALT, PT, INR. Which do you think is the most correct? Are all included in it? And I will close the poll in 5, 4, 3, 2, 1, 0. We can go to the next poll. Okay. The next one is, we had childpox in the second question. We'll go to the third question. The third question, and which is the correct combination of parameters essential to calculate for the MELD score or the model for end-stage liver disease score. So which is the correct combination? Is it a combination of bilirubin, creatinine, INR, or a combination of bilirubin, urea, and INR? Combination of bilirubin, creatinine, and P time, or albumin, creatinine, and INR? Which do you think is the correct combination? So if you think it is 2, click on 2. If it is 3, click on 3. If it is 1, click on 1. If it is 4, click on 4. And we will close the poll in 5, 4, 3, 2, 1, and 0. And we'll go to the next poll question. So this is about decision making. We'll go to the next, and can you get the next poll question in? This is about decision making. A 70-year-old male who's known cirrhotic comes with complaints of pain abdomen, gallstones. He has gallstones, and the plan is a laparoscopic cholecystectomy. On examination, the 70-year-old is lethargic and confused. Bilirubin is 2.5, albumin is 4, INR is 1.4. And in this setting, what would be your plan? Would you do a gastro consult or hepatic consult and proceed for surgery? Do your gastric consult, give preoperative fresh frozen plasma and vitamin K, proceed for surgery with a high-risk consent? Do a gastro or hepatic consult, give preoperative plasma, vitamin K, recheck the INR, and then decide? Or you say, no, this is unacceptable risk, we'll cancel the elective surgery. 70-year-old, cirrhotic, known, pain abdomen, has gallstones, plan is a laparoscopic cholecystectomy. Lethargic and confused, bilirubin 2.5, albumin 4, INR 1.4. What would be your plan? Proceed for surgery after a gastro consult, pre-op FFP vitamin K, proceed for surgery with a high-risk consent, FFP vitamin K, recheck INR, gastro consult, and then decide? Or you say, no, this is unacceptable risk, we'll cancel the elective surgery. So we'll close the poll in 5, 4, 3, 2, 1, and 0. And we'll go to the next poll question. The next one, question number 5, is 70-year-old, cirrhotic, same, pain abdomen, gallstones, laparoscopic cholecystectomy. He has a child score of 5, a MELD score of 9, a hemoglobin of 10, and a platelet count of 75,000. In this case, what would be your plan? A gastro consult and proceed for surgery, a consult gastro, pre-op platelet transfusion, proceed for surgery with high risk, consent, gastro or hepatic consult, give preoperative platelets, recheck the platelet count and decide after that? Or you say, no, this is unacceptable risk, we'll have to cancel the elective surgery. 70-year-old, cirrhotic, pain abdomen, gallstones, laparoscopic cholecystectomy is the plan. Child score 5, MELD score 9, hemoglobin 10. Just proceed for surgery after a hepatic consult. Gastro consult, pre-op platelets, proceed for surgery with a high-risk consent. Gastro consult, pre-op platelets, recheck the platelet counts and then decide. Unacceptable risk, cancel elective surgery. And we'll close the poll in 5, 4, 3, 2, 1, and 0. And we'll go to the last poll question before we proceed with the presentation. And this is a 70-year-old, cirrhotic, again, I'm stuck on cirrhosis. He has a CA colon and is undergoing hemicolectomy. What would be your perioperative hemodynamic plan for this person? And in hemodynamics, you'll figure out it's about monitoring, it's about fluids, and it's about vasopressors. So is your plan liberal fluid therapy with cardiac output monitoring and avoiding vasopressors? Or is your plan restrictive fluid therapy and intraarterial catheter, looking at pulse pressure variation and early use of vasopressors? Or is it restrictive fluid therapy, intraarterial catheters, catheter in situ, pulse pressure variation monitoring, avoid vasopressors? Or is it liberal blood pressure, early use of vasopressors? What would be your ideal approach? Hemicolectomy for CA colon in a patient with cirrhosis, what is your plan? Liberal fluid therapy, cardiac output monitoring, avoiding vasopressors, restrictive fluid therapy, intraarterial catheter with pulse pressure variation, early use of vasopressors, restrictive fluid therapy, intraarterial catheter and pulse pressure variation, avoiding vasopressors, liberal fluid therapy, non-invasive blood pressure, early use of vasopressors. So think about this, and we'll close the poll in 5, 4, 3, 2, 1, and 0. And thank you all for participating. We will proceed to thinking about how to screen for liver disease before surgery. Essentially, again, good old textbook teaching is from history and physical examination. And from the history, things that can give you a clue are prior blood transfusion, tattoos, illicit drug use, multiple sexual partners, and history of sexually transmitted diseases, family history of jaundice or liver disease, jaundice and fever following anesthesia in the past, alcohol use, and a review of current medications. These are things pointers in the history. Okay, yeah. What to look for? Suggestive of liver disease, examination, fatigue, pruritus, increased abdominal GERD, jaundice, palmar erythema, spider telangiectasia, splenomegaly. So these are, again, kind of markers which should make you aware that this person might have a liver disease with the thing. What is the role of preoperative evaluation? That will be true for anything, whether it is liver disease, for heart disease, pulmonary disease. You try to find out the etiology of the disease, the duration and the severity, and you risk stratify, and then you do optimization of the medical status. So the risk stratification is with the patient and the liver, and obviously the surgery. These are the two pillars. We knew about this from our cardiac evaluation, from our pulmonary evaluation, etc. About the liver disease, there are certain things which are of unacceptable risk, and with those you just cannot think of contemplating elective surgery. There are things which are the most discussed, as I was talking about. Cirrhosis, obstructive jaundice are the ones with variable increased risk. There are things with minimal risk, and in these situations, if it is you have to take a call and possibly think about going ahead with unplanned elective surgery. Mild chronic hepatitis, fatty liver, autoimmune hepatitis, and things like hemochromatosis. For the non-hepatic surgeries, in a patient with liver dysfunction, cardiac surgery possibly has the highest risk, and then is abdominal surgeries, and then as in all other aspects, it is also emergency surgeries. It's essentially because you don't have the time to optimize. So who are these patients on whom elective surgery is an absolute no because of the unacceptable mortality? You are not going to touch these patients with your barge pole. Anybody who has features of acute alcoholic hepatitis, acute liver failure, acute viral hepatitis, a Child-Pugh score of class C, a score which gives you a class C cirrhosis, or somebody with severe chronic hepatitis. And this was given by Friedman in the year 1919, and it is so true even today. Along with it, if you find there is severe coagulopathy in your evaluation, a prolongation of prothrombin time beyond 3 seconds despite vitamin K administration, a platelet count of less than 50,000, and an added on extrahepatic complications like an acute renal failure, presence of a severe cardiomyopathy and heart failure, along with hypoxemia. So this is where you say no. If these are the conditions present, it is wiser to wait till they settle and then possibly think of an elective non-hepatic surgery. When will you suspect? If they show you signs of hepatic encephalopathy, a prolonged INR of greater than 1.5, severe jaundice, on examination, tender hepatomegaly, or a right upper quadrant tenderness. So these are markers that should alert you that this person can have those things. And I think hepatic encephalopathy for students, I think you can be This is a very old favorite of examiners. What are the grades? When do you think it is? There's a short note.
Yeah.
So just go through this about the hepatic encephalopathy bit. And these are clinical features of hepatic encephalopathy, which I think everybody reads through during their final years in MBBS and even today. So why estimate the surgical anesthesia risk is, again, appraisal of the severity, urgency of the surgery, the coexisting medical illness, and whether you can optimize, wait, and then go ahead, or no, this person needs to get his liver fixed first and think about liver transplantation even before you think elective surgery. If you look at estimating this risk, it has been very well talked about, discussed. There is huge amount of evidence with a patient with a cirrhosis. Most of it has been patients who have developed cirrhosis. Much less information has been published on the risk of surgery in a patient with other advanced forms of liver disease. So unfortunately, the literature is short on it. So the patient with a variable risk, we talked about it, the cirrhosis and obstructive surgery, obstructive jaundice, and the types of surgery. I think we talked about abdominal cardiac emergency, hepatic resection, which Dr. Shweta will take you through. What are the markers? I think this is, people realize that these things are individual prognostic markers for poor performance for a non-hepatic surgery in a patient with cirrhosis. Anemia, ascites, a child class of C and more, C. Encephalopathy, hypoalbuminemia, hypoxemia, infection, jaundice, malnutrition, portal hypertension, and a prolonged prothrombin time. And the predictors of risk were given through the Child-Pugh score. It came in 1964. With the advent of the 21st century, many people say that beyond the Child-Pugh score, the model for end-stage liver disease score, or the MELD score, possibly is superior in most respects, especially when you're trying to prognosticate for a non-hepatic surgery and for liver transplantation. I'm sorry. Okay, so the Child-Pugh score came in 1964, and it was originally for surgery for portal hypertension in cirrhosis. They started off with 2 continuous variables like bilirubin and albumin, and 3 discrete variables, ascites, encephalopathy, and nutritional status. 73, it was modified, and nutritional status was removed. It was replaced by prothrombin time. Initially, it was the delay in prothrombin time. It was later on replaced as an alternative by the INR. So when you're today doing it, do not try to give a score for both INR as well as for prolongation of prothrombin time. Essentially, it has 5 parameters. You will score it in 1, 2, and 3. Give them scores in each of the parameters. You calculate the total scores and then assign them to a class of whether A, B, or C. And then finally predict a 1 or 2 year survival kind of status. So that is what you would do with this. So let us look at it. So you see the parameters are on the left hand side, and you give the points aside based upon what? I think I will not waste your time on this. You see, again, it's ascites, absent, slight, or moderate. Bilirubin and its levels, where you score, give what scores. Albumin, 3.5. If it is above, they score 1. Less than 2.1, 2.8, they score 3. It is either prothrombin time, and I think it is easier to remember it just with INR, and less than 1.7, greater than 2.3, 1, 2, and 3, and the presence or absence of encephalopathy and its grades. So then you give them the scores on these 5, okay, and get them to what is the total score. Essentially, if they're scoring 1 on each and a maximum of 2 on 1, then their significant functional compromise, and 10 to 15 is a decompensated disease. This is again somebody you would possibly not take up who's coming for an elective non-hepatic surgery. And it's if nothing is done at that point of time, you see that in grade C, without an active management, half of the patients will die within a year's time. How do they predict in non-hepatic? Let's look at it. In 1984, I'll just give you alcoholic cirrhosis, abdominal surgery. Again, it is kind of nearly predicting the way it was predicting for even mortality. Even in, a little later on, 1997, you see it is still predicting similar to what was thought that it should do. So many people think that the way of improving this child PUG could have been by increasing other markers of liver function like clearance of galactose, indocyan in green, aminopyrin and lidocaine. Unfortunately, the results from this have been pretty bad, and they have not added an additional value. And incorporation of conventional markers in nutritional status have also been of limited value in this scenario. The critiques would say that the variables that were decided by Child, PUG, and Tourette were selected empirically, and they were not always independent prognostic markers for bad prognosis or predictors of bad prognosis. Things like albumin and prothrombin time are looking at the same kind of things, so the both together are redundant. The cutoff value for each value again has been empirically selected, and no kind of thing has said that about this translation from 1, 2, and 3 not well defined. This limits for qualitative variables like ascites and encephalopathy is completely to the clinicians, and his subjective interpretation becomes very important. It does not consider certain specific variables like creatinine, which have shown now that it is an important prognostic marker, and the etiology of the liver disease, which plays a huge factor in determining outcomes, whether it is alcoholic cirrhosis or it is an active viral hepatitis B, which is causing that with a replicating virus, which can make a huge difference to the prognosis. So these are the critiques of the child PUG score, which brings us to the MELD scores. It's a prognostical model, and it is helpful for medical decision making, and it takes into account statistical methodologies. And if people who are interested in AI, this is possibly one of the first applications of AI in medicine. It was originally, like child PUG was for portal hypertension surgeries. This was for TIPS. And the original model included bilirubin, creatinine, INR, and the etiology, which was subsequently removed. If you were interested in statistics, this is how the statistics has been worked on. They look into the log of the scores and they sum it up. It has been an accurate predictor for TIPS, and therefore it was hypothesized that it could be in good prognostic indicator in patients with advanced liver disease not undergoing TIPS, and useful in predicting mortality. And that's why it has been used as to determine the waiting list for liver transplantation. And this is the very, very kind of famous, if I can say, infamous rather, the MELD score Kaplan-Meier curve, which kind of determines who with what score is going to survive beyond a certain period of time, and unless a liver transplantation is done. Because people figured out that vasodilatory state is very common in patients with cirrhosis, and a low sodium results therefore, and therefore many people say that MELD sodium score is a better prognostic indicator for risk prognostication. How do you calculate? I think there are several. If you look at MedCalc or whatever, you will find there are several ways of online MELD score calculators. All you have to feed it in is the serum bilirubin, creatinine, and the INR, and it will give you the MELD score. This is kind of giving you an example. The one that I have looked in, this one gives you whether the person has undergone dialysis twice or greater than 24 hours in the last week. And you feed in the values, you get the MELD score. So if you feed in values like a creatinine of 3 with a bilirubin of 10 with an INR of 3, it will give you a MELD score of 38. And contrast this, if it's a creatinine of 1 with a bilirubin of 5 with an INR of 1, you get a MELD score of 13. So it gives you an online calculation and helps to prognosticate and then decide. There are several studies which are looked into how well it helps you in prognostication and deciding, helps in decision making. So if you look at 30-day, 90-day mortality for patients undergoing major GI, orthopedic, cardiovascular surgery, this was in 2007. The mortality at 30 days ranged from 6% with a MELD score of less than 8 to more than 50% when the MELD score went above 20. So there was a linear increase with the linear increase in MELD scores. Even laparoscopic cholecystectomy, what has been seen is that a MELD score of greater than 8 was useful for predicting morbidity. For abdominal surgery in cirrhotics, a MELD score of greater than 14 was predictor of poor outcomes, and it was better than the child scores. A MELD score of greater than 15 with an albumin of less than 2.5 predicted significantly increased mortality. And even a hepatectomy in hepatocellular CA with a MELD score of greater than 11 was a high risk of post-operative liver failure. What I'm coming to is that this MELD scores can help you prognosticate and can help you kind of taking this shared decision making. What can be improved? People realize that if you can add the patient's age and the ASA class along with it, which takes in the other comorbidities, it gives you a better estimation. And this is the other MELD score modified that I like to use most often, which gives you the age, the ASA class, again, and the same bilirubin, creatinine, INR, and which was originally removed is you add to it is the cirrhosis etiology. So if you look at it, 70-year-old ASA class 3, bilirubin 5, creatinine 1, INR 1, alcoholic cirrhosis, you get a MELD score then of 6, and the mortality after 90 days is 10%. I just change it and I make 70-year-old ASA class 4 when this is another severe systemic disease. Bilirubin is 5, but creatinine is 3 and INR is 2.5. And if it is a viral etiology, you'll find that the MELD score is much, much, much higher. So it helps you to kind of understand that is. But this is, I think, the take-home slide for MELD scores. If it is less than 10, the approach would be that it is good enough to go ahead for an elective surgery. If it is 10 to 15, elective surgery can happen, but with caution, and you have to really weigh the risk benefit. If it is greater than 15, they should not undergo an elective surgery. So that was about cirrhosis. Coming to obstructive jaundice, the problems with obstructive jaundice is infection, and this is because of the bacterial colonization. The other things are more surgical oriented, stress ulceration, DIC, wound dehiscence, but remember they can go into renal failure, and it has a significantly high perioperative mortality up to 28%. The mortality predictors could be initial hematocrit of less than 30%, a serum bilirubin which is above 11, and if the cause of obstruction is a malignant cause. If all three factors are present, the mortality approaches around 60%. And if none of them are present, hematocrit more than 30, bilirubin less than 11, non-malignant cause, mortality is much lower, 5%. And this is the take-home message, again, slide from obstructive jaundice. Again, these are the risk factors with obstructive jaundice. What can you do to reduce the mortality and morbidity in obstructive jaundice? Preoperative broad-spectrum antibiotics. I think this most of your hepatologist or gastroenterologist will do an external biliary drainage transhepatic, or most often would be, if possible, an endoscopic biliary drainage, a stent or a plastic stent or whatever, and administration of bile salts or lactulose, which can prevent the endotoxemia and the endotoxemia-induced renal vasoconstriction. Risks, again, I think this we have discussed. I'll not take you through this. Importantly, the risk during surgery is because of the reduction in hepatic blood flows, and less invasive procedures today are like laparoscopy has reduced the risk significantly than, say, 20 years back. Minimally increased risk are those with, I talked about it, chronic, mild to moderate chronic liver disease. They usually would tolerate the surgery well. What investigations would you do? I think this is a standard investigation. We see the panel on the left-hand side. This, for any surgery, they would go through this: hemoglobin, white cell count, platelet count, electrolytes, glucose, blood urea, and the creatinine. Additionally, you do prothrombin-tine INR, APTT, and fibrinogen, and obviously the transaminases levels, bilirubin and albumin. And based upon other patient comorbidities, cardiac, further investigations or pulmonary, you can do. Imaging in certain areas, more important for surgical reasons, and volumetric studies, which I think will be discussed. This is again the take-home slide for investigations and how investigations differ between the types of liver disease. I think just go through it at some point of time. And like in hepatocellular injury, the transaminases is high, the albumin is reduced, P times are prolonged. Albumin may become normal in acute fulminant hepatic failure. That's a complete different reason. Bilirubin is a conjugated hyperbilirubinemia. Alkaline phosphatase is usually normal, but in infiltrative liver disease, it can increase. GGT remains normal. Alkaline phosphatase, GGT, all of you would know that are increased in the obstructive kind or cholestasis. So this is again something you can take your time and go through. This, I think, is a controversial area. Should we do liver function tests in every patient without known liver disease? The answer to that is no, but you might find that it is quite often done. When it is done, look at what the values are. If it is less than twice the normal range, then it's possibly reasonable to repeat the abnormal test to make sure that they are not increasing. If the results are greater than twice the normal range, then elective surgery should be at least withheld, and you possibly think of evaluating the scenario, and if possible, is there a role in optimization? With a known liver disease, you obviously would definitely do a liver function test, and liver function tests are elevated in most liver disease and also in disorders that would involve the liver, like any infections which involve the liver, acute and chronic heart failure, metastatic carcinomas. Highest elevations are seen in acute viral hepatitis, shock liver, or a drug or toxin-induced liver injuries. And in this scenario, these are all contraindications to elective surgery. So hugely elevated transaminases, think twice before taking these patients for elective surgery. What are the evaluation of the other organ systems? Encephalopathy, hematological abnormalities, cardiovascular, pulmonary, portal hypertension. I'll quickly take you through this. Encephalopathy, I think all of you know that what are the things that you try to avoid when you think this is done, and you do not give drugs like benzodiazepines as sedatives. Hematological, this is something that I will just delve a little bit more. Diminished hepatic functions as both procoagulant and anticoagulant effects. What now is they talk about is this results in a rebalanced hemostasis. The tests of coagulation in liver disease, you will find prolongations of prothrombin time, INR, APTT. There is mild thrombocytopenia, and how important it is, we'll figure it out. Elevated D dimers, especially when the liver synthetic function is more significantly impaired and portal pressures are increased. So you'll find changes over happening here. But do they predict the risk of bleeding? This P time, INR, APTT, platelet count are very poor at predicting the risk of bleeding. They only reflect the change in the procoagulant factors, and prolongation of INR may reflect the instability of the hemostatic balance, but not of the hypo or the hypercoagulability in cirrhosis. So what do? Possibly viscoelastic tests are of great help in patients with hepatic dysfunctions. And these are things like TEG or thromboelastometry, and they might guide you in correcting the abnormalities in these patients with liver disease. And it has been seen in literature that TEG guidance has decreased the perioperative bleeding and reduce the transfusion of blood products. So if you are anticipating surgery and in a patient with liver disease with abnormal hemostatic laboratory tests, what will you do? Would you give vitamin K? Yes. If you give it when there is a suspected deficiency like poor nutrition, cirrhosis, cholestatic disease, and antibiotic use. If you're thinking of microvascular bleeding or those at increased risk of bleeding due to a percutaneous procedures, both pre-op and intra-op, what will you do? Give platelets to achieve a platelet count of 50,000. Target platelet count is 50,000 for most surgeries. Give cryoprecipitates to get a fibrinogen levels above 200 milligram per DL. This is possibly a very important marker. If you have the ability to look at fibrinogen levels and you're suspecting bleeding, I think the go-to would be cryoprecipitate. So far, if you scan literature, there has been hardly any recommendations which will tell you to administer FFP to correct the INR in patients with liver disease. If the platelet counts are low, you can think of thrombopoietin receptor agonists, but remember, it has to be started much earlier. Nearly takes 10 days to have an effect. For closed cavity surgeries like craniotomy, the hemostatic management has to be individualized, and you need possibly a more aggressive effort, with cryoprecipitate. And in these, the platelet count target, I have not put it in the slide, is 1 lakh and not 50,000. So you have to individualize when you think that the consequence of an hematoma is large. So going from hemostasis to cardiovascular, they have hyperdynamic circulation with a low SVR and a high cardiac output. And worsening liver hepatic function causes worsening cardiac function. You have a situation like a cirrhotic cardiomyopathy. You might have usually a normal or increased cardiac output and contractility at rest, but the response to a pharmacological, physiological, or a pathological stress is not there, and it can result in a heart failure. So your perioperative fluid therapy has to be well thought of, and you should not be thinking of overloading. Coronary artery disease is usually age matched, but there are certain diseases like NASH, non-alcoholic fatty liver, hepatitis C, but the association with the coronary artery disease and its morbidity mortality is higher. Be aware of this. Patients with cirrhosis, portal hypertension would be on beta blockers, and these patients would be more prone to a perioperative hypotension. And if you're trying to think of screening tests like dobutamine stress echocardiography, the patients you will not get an answer to that because the heart rate is blocked. There is a huge role of doing a echo screening in these patients because you can pick up portopulmonary hypertension with a pulmonary artery pressure of 50. And if you see that, that is a no-no to elective surgery and possibly even a no-no to transplantation. Pulmonary complications are mainly due to ascites when they have shortness of breath, and for anesthesia, you can have difficulty when they are lying supine during induction, or even you are doing things with max spontaneously breathing regional anesthesia as well. If you have, because since they can have also surgical poor outcomes, it needs to be treated aggressively, diuretics pre-op, or if you think that you do not have the time, then is laparotomy and draining it out. The other thing is this hepatopulmonary syndrome, which is because of this intrapulmonary vascular dilatations, because of ventilation perfusion mismatch and there's oxygen diffusion mismatch, and they require an supplemental oxygen and higher FiO2 during surgery. And essentially what happens is your pulmonary vasculature gets dilated, and even for the same amount of the partial pressure of oxygen in the alveolus, the partial pressure of oxygen in the arteries do not rise unless you supplement with a higher FiO2. And this diagram explains how it happens. This is the normal thing, and this is what happens in pulmonary vasodilatation, and oxygenation suffers. Varices, the treatment is with beta blockers. The perioperative goal is to see that the CVP stays low and fluid overload to be avoided at always. Renal dysfunction, I'll just take a little bit of time on this. There is a progressive decline in renal function, which is characterized by retention of sodium and free water. And renal hypoperfusion is possibly what leads to this. There is decreased glomerular filtration, and this leads to what is, again, a favorite of examiners, both in oral and in theory, hepatorenal syndrome. But hepatorenal syndrome is a diagnosis of exclusion. There could be other reasons of renal dysfunction in patients with cirrhosis, per se parenchymal renal disease, sepsis, nephrotoxicity, and hypovolemia. Hepatorenal syndrome, the pathogenesis is an arterial vasodilatation in the splanchnic circulation triggered by this portal hypertension. And presumed mechanism is this vasodilatory things in the splanchnic circulation, out of which nitric oxide is the most important. There is a progressive rise in cardiac output with a fall in SVR, and this fall in SVR is despite that in the locally the renal angiotensin axis is hyperstimulated, that there is increased renin in the system. And this, again, this bar diagram will tell you what actually happens. They become less and less responsive to vasopressing agents. So it is a decline in renal perfusion, reduction in GFR, reduction in sodium excretion, and this is one of the clues towards an hepatorenal syndrome happening, which is a urinary sodium of less than 10 milliequivalent per day in advanced cirrhosis, a fall in MAP despite an intense renal vasoconstriction. So it's a diagnosis of exclusion in a patient with liver disease, with progressive rise in creatinine, minimal proteinuria, low rate of sodium excretion, or they can be non-oliguric or oliguric, depending upon the severity. How bad is it? You assess through blood urea nitrogen and creatinine, but remember this can overestimate because these are proteins. This needs to be synthesized in the liver, and so you might have lower values with a much higher renal dysfunction. Be aware of that. Monitoring is urine output, hyperkalemia and acidosis avoidance, and limiting exposure to nephrotoxins and aminoglycosides. Electrolyte abnormalities. Be aware that there will be hyponatremia. Don't try to be overzealous in correcting unless you find features of severe hyponatremia or the sodium goes below 120. Correct it slowly. Nutrition, again, needs to be corrected, and there are various modalities of correcting. What about an intraoperative management monitoring? Standard monitors, but there is a very low threshold for putting in an intraarterial catheter because it helps you in understanding the dynamic pressure management. Role of CVP is controversial. I would put in a central venous catheter, which will possibly, when I think that I will definitely need vasopressors, and you might need vasopressors in this group of patients. Choice of anesthesia technique, I think it has not mattered significantly, neuroaxial, general, or MAC. Just certain things, when you're giving neuroaxial, obviously, once the coagulation status is okay. But remember, the hypotension can be more severe than in those without liver disease because of this reduced hepatic blood flow. You'd have to give vasopressors and fluids, but the effectiveness of vasopressors on the hepatic blood flow is something which is conflicting, and which is why many people will be really concerned about giving a high thoracic neuraxial block like T4, which significantly reduces hepatic blood flow. If you're trying to find out what is the cutoff values, lab values for platelet count or INR, for which you should go ahead and give a neuraxial anesthesia, unfortunately, the literature with liver dysfunction does not give you any cutoff values. So you'll have to take a call depending upon an individual patient. Liver and the anesthetics, what does the liver do to the drugs and what does the drug to the liver? Anesthetics on the liver, it's essentially about the hepatic blood flow and toxins. Just about volatile anesthetics, they decrease the hepatic blood flow, most of them. At 1 MAC, isoflurane and sevoflurane have very little reduction, whereas desflurane reduces it more by around 30%. Halothane produces a greater reduction in cardiac output and hepatic oxygen supply than any other volatile anesthetic agents. The hepatotoxicity is because of this trifluoroacetyl chloride, which is produced 20% in halothane, 0.2% in isoflurane, and 0.02% in desflurane, which is possibly what we used to think about halothane hepatitis. This TFA is not produced by sevoflurane. Sevoflurane metabolism is a fluoride, and this fluoride metabolite, as well as this compound A, has not yet even theoretically shown to have caused hepatic damage. Nitrous, usually nothing that it causes, but there's concern about methionine, especially if it is B12 depleted in liver disease. IV anesthetics, as long as the cardiac output and blood pressures are managed, I think you don't need to be thinking. What does the liver disease do to the drugs? Pharmacokinetics, it can cause changes in protein binding, more importantly about volume distribution. Drug removal can be a concern because of the portocaval shunting, the hemodynamic changes, and the reduced hepatic inflow. With high extraction ratios like lignocaine and meperidine, they are affected by the reduction in hepatic blood flow more. In low extraction ratios, it is more about dysfunction that causes the changes. Feel free to use any IV induction agents, no harm on that. If only thing, be aware about the pharmacodynamic effects of this, like hypotension. Benzodiazepines, again, preferably avoided in more severe disease, but just you have to reduce the dose. I think just a time on neuromuscular blocking agents, saxamethonium, because of plasma cholinesterase, and which produced in these advanced liver disease, the duration of action might be increased. How much it has relevance in clinical outcomes still to be decided. Mivacurium, the same problem. Rocuronium and vecuronium, clearance, elimination, and the duration of neuromuscular block are prolonged in patients with advanced liver disease. But remember, there will be resistance to the initial dose because of this increased volume of distribution. And so just be aware of that increased duration even you're using the aminosteroids. Best drugs to use possibly would be atracurium and cisatracurium because of their organ-independent elimination. So goals for hemodynamic management is maintenance of hepatic perfusion, and especially for those undergoing abdominal surgery, ensure that there is decreasing portal pressure so that the bleeding is decreased. Goal blood pressure is the patient's baseline. Remember, they have a hyperdynamic circulation with a very low SVR, so there will be borderline hypotension, and they will require vasopressors early on to avoid hypotension during induction and maintenance. And they will be more kind of resistant to the use of even exogenous vasoconstrictors, including vasopressins. So not only would you need noradrenaline and vasopressors to maintain the blood pressure, be aware that you might usually need a little higher doses of these when you're trying to take control of the vasopressors. So the goal would be restrictive fluid therapy because you don't want to overload, especially with portal hypertension, varices. Keep the CVP low. Better would be to look at the dynamic parameters like pulse pressure variation, ensure lower portal pressures to reduce the bleeding, and early use of vasopressin. People have thought that maybe IV albumin may be a better choice in certain areas, especially after paracentesis or when you're suspecting spontaneous bacterial peritonitis, or to prevent HRS in conjunction with splanchnic vasoconstrictors. Ventilation, I think, is the same. Low tidal volume PEEP, intermittent lung recruitment. I'll just get back again to this hemostasis because this is the bugbear of liver dysfunction and non-hepatic surgery. So the role of PTINR, I think we talked about this. Target platelet count is 50,000, but if it is craniotomy, closed cavity, target platelet count is 1 lakh. Viscoelastic tests like TEG and ROTEM possibly is better. It helps you to kind of direct your therapy. Fibrinology, fibrinogen plays a huge role in the clot stabilization, and it is wise to keep it possibly above 200. And cryoprecipitate is possibly the preferred way of giving it rather than fresh frozen plasma if you have the ability, if finances is not a concern. Abnormalities in platelet numbers. So why 50,000 you allow is because the platelet function in liver disease are part compensated by this. This is what we now know. There is this procoagulant activity by increased levels of von Willebrand factor and a decreased levels of, you want to remember it, try to remember it, Adams 13. And thrombin generation is well preserved with the platelet counts exceeding 50,000. So that's why it is 50,000. PRBC transfusion, it is the same, and it will be guided by other comorbidities as well. Post-operative monitoring, be aware of worsening jaundice, encephalopathy, and ascites. Post-operative monitoring usually is with bilirubin, PT-INR, renal functions, electrolytes, and glucose. Liver function test, what do you do if you see changes less than twice? It is usually occurs frequently after surgery. Don't get too much bothered about it. It's typically transient and of no clinical consequence. More than that, maybe could be an intraoperative event like hypoxemia or hypoperfusion, could be due to trauma. Any hepatic surgery would lead to that, or a chemical toxicity, typically drug induced. And also common causes are reabsorption of the surgical or traumatic hematomas, or red cell transfusion, or massive intraoperative blood transfusion, which causes a huge bilirubin load. So that is about it, and we will wind up with the answers to the audience questions. This is what we had asked. What is most likely to be encountered in a patient with advanced cirrhosis of the liver? And you will find increased transaminases, increased conjugated bilirubin, decreased albumin, increased p-time, and a normal alk phos. So these are the take-home messages as well, what is from what you heard for the last 1 hour possibly. Correct combination for in the child-pug Tourette scores. The answer is encephalopathy, ascites, bilirubin, albumin, PT, or INR. I think it's better to remember just INR. In the MELD scores, what are taken care of? I think you would possibly now answer it absolutely correctly. It is just bilirubin, creatinine, and INR. And then you had modifications, but about MELD scores, all you have to feed in is bilirubin, creatinine, and INR. So what will you do with somebody's cirrhosis waiting for a laparoscopic cholecystectomy but is lethargic and confused? I think the answer is simple. This is unacceptable risk. You cancel the elective surgery. Lethargic, confused, you think this is just subtle changes that the patient might be going towards hepatic encephalopathy. Unacceptable risk. You cancel elective surgery. MELD score 9, CP score 5, platelet 75,000, cirrhosis. What will you do? I think we talked about this. Consult and then take a collective decision and proceed for surgery. No need of platelet transfusion in this scenario. Hemicolectomy, cirrhosis, hemodynamic goals. I think by this last few slides, you should have got this, is restrictive fluid therapy. You would put low threshold for an intraarterial catheter, look at pulse pressure variation to guide, and early use of vasopressors and possibly greater use of vasopressors. So thank you very much.